Clustering. This is another example. This is second-line renal cell carcinoma. A rather nasty condition, but the good news is there's quite a few treatments that to some extent work. There were already existing treatments. I've forgotten what the dominant one was, but from January 2016, we've had a succession of new treatments introduced. Nivolumab, everolimus, cabozantinib, and then lenvatinib plus everolimus. Now, this bit, scope, is when the issue was identified. This is a new drug. These are the likely comparators. Identifying the decision problem. Guidance, moving forward in time, is when eventually a decision was made and the guidance was issued. So if you like, this length of the line here is essentially the time it's taken to go from saying, I think we need an evaluation of this, to a statement about yes or no and why, a decision. And as you'll see, we've got a sort of clustering or overlapping. Before nivolumab appraisal was resolved, everolimus was underway. Before everolimus was resolved, cabozantinib was being evaluated, and so on with lenvatinib. Now, that is going to be a real decision-making challenge. So, what should everolimus be compared to? Well, probably it should be compared to nivolumab. But as it's been kicked off before nivolumab was approved, everolimus wasn't getting compared to nivolumab. And then before everolimus concludes, in fact, indeed, before nivolumab concludes, cabozantinib appraisal started. And so again, you might say, well, what we really want to know is how cabozantinib compares to everolimus and nivolumab. But actually, and I can't remember the drug before, we're comparing all three of them to something that was used several years earlier. So it's a challenge. I mean, it's great that we've got these new technologies coming along, but it's like buses, isn't it? You wait for a bus, not in Japan probably, but in other countries you wait for a bus, you wait a long, long time, and then three come together. I'm sure in Japan that never happens. I have to adjust my talks culturally. Yeah. So this sort of sequential decision making in the presence of a treatment cluster is quite difficult. There's an issue around what you compare to. Another problem is disagreement regarding common comparators. So these appraisals will each have had to make some assumption about how we're going to model survival. They'll have all had to make assumptions about what score do we attach to stable disease health state? What score do we attach to progressed disease? Now, you'd rather want them to make similar assumptions so you can get a better comparison, more consistent comparison. But of course, the case is being made by different manufacturers. And manufacturers tend to make the case as strong as it can be for their own product. So there is frequently quite a lot of disagreement about these common shared comparators. They're all these cases, they're all looking at the same decision problem. This was an example of second-line metastatic renal cell carcinoma. Frequently they've got different model structures. And again, that makes comparison harder. And then in some ways the saddest element is this hidden data. The sum of what we know about these drugs is much greater than what any single appraisal knows about the drugs. So the manufacturers, for good commercial reasons, are not sharing information with each other. Now, of course, if you said, well, let's look at all these drugs together, let's pool all the information, one would anticipate we'll get a much better decision as to what is the best way to treat these patients. By best, I mean not just most effective, I mean best value for money. But we don't. We're taking individual sequential decisions and we're not sharing data. So it's a challenge. Right. That was a clustering. Yeah, I've mentioned stakeholder engagement. Yes, the budget. I want to say a little bit more about the need to have the budget matching in some way or consistent with the cost effectiveness threshold. Where's it gone? Yes. Right, a graph. I'm afraid economists love graphs. That's because they're not clever enough to use equations. We like equations as well, but graphs we love. Pictures. Imagine along the horizontal, we're measuring, in this case, NHS expenditure per year, substitute Japanese system or any other country you wish. So this is the amount of resource going into healthcare each year. And so just now, the budget is at this level E. And that's the total amount we're spending on healthcare. On the vertical, we're measuring marginal health gain. So what health benefit are we getting? Probably measured with QALYs. What health benefit are we getting from the money we're spending? Now, as a sort of thought experiment, you could take everything we're currently providing and order these activities in terms, starting with those that give you the most health gain. And then less health gain, and so on. Okay, so the marginal health gain an activity gives us. And we're ordering the activities so that we've got the activities that produce the highest marginal health gain up here and the lowest down here. Okay, now in this example, I'm being quite kind to the health system and saying that even the worst thing we're doing to patients, even the worst activity, is still producing a positive benefit. EA. Okay, so that's everything we're currently doing. Now imagine everything that we're not doing. We're not providing. So there's a series of things we could be doing for patients. This might be new drugs or whatever, diagnostic tests, you name it. And we could order them in terms of those activities which produce the highest marginal health gain down to the lowest. Okay, so the line HA is everything we're currently providing. The line CF is the things we're not providing. So now imagine we did everything. So we sum together, adding horizontally, the two curves. So we get a new curve, new line, H, D, B, E, F. That's adding horizontally. That's if we did everything. If we did the things we're currently doing, but we also did all the things we're not currently providing. Okay, now imagine the budget has remained the same though. The best we could do with this budget would be achieving a marginal health gain of EB on that would be our least, as it were, productive activity. Right now, the activity that's giving us the least benefit is here. It's got the marginal health gain of EA. And so looked at this way, we should really stop doing these activities or stop giving these drugs, treatments, and using the money released, we should start doing these activities. These are the best things we're not doing just now that we could be doing. These are the worst things we're doing just now that perhaps we shouldn't be doing. Now, if that's to happen, if we had a cost-effectiveness threshold at EB, then there's no problem of the budget and the threshold being out of line. They're consistent with each other. If we had a cost-effectiveness threshold which implied an activity must have a marginal health gain of EB, and if it doesn't, it shouldn't be done. If it does, it should be done. If we did that, we could afford to do everything that meets that threshold. The budget's big enough. But there's no mechanism to make that happen currently. And therein lies the problem. So for example, in England, as I was saying earlier, it looks as if the NHS can turn money into health at about £13,000 per QALY. Meanwhile, we've got a cost-effectiveness threshold of 20 to 30,000, and so new technologies are being approved which are actually going to reduce health in the system, because by paying for the new technology, you're giving up some existing technologies, and those existing technologies can produce QALYs at £13,000. So that's a problem, a challenge, getting the cost-effectiveness thresholds and the budget into line.